Yeah.
Yeah, whatever.
Can I get another one of these to give to Kristen?
Oh, yeah. Right, that's, I think, the other. Yeah.
So we usually do right. Travel right.
I enjoyed that meeting.
It was good, yeah. No, it was good.
Lake, like south.
I'm like you, it's kind of almost surreal to see how much has happened. Really, a pretty short amount of time.
I guess. So, of course, it's like the ways to.
Yeah, I
Yeah, so
agree. I
it's
think
like-
there's some helpful things come out of there too, because
You can find, yeah.
a lot of the judges were surprised to see their counties. On that
No,
map.
we live.
That's area.
I did the road, I mean.
And so we've been able to get a few of them directly connected now
Yeah.
That's only.
with their people doing local basis.
So if we continue we will continue the commission. Should we put somebody from judiciary on the
I think so.
commission?
Well, and you can even say,
You guys would like to stay involved, wouldn't you?
Yeah.
I think it would make sense if we end up suggesting commentary to do this criminal justice piece.
Yeah.
I just, it has, like, you can't, you have to go a level below.
Wow.
Like, that's the one thing with criminal justice, and that, like, in California now, they're doing all this things about like involuntary treatment, voluntary treatment, that's their big push. Involuntary treatment. Like, okay, I understand where that comes from. And you know, maybe there's a place for something like that, but like, that's because that's what the right is. You're not addressing in any way, shape, or form.
You were seated close to the.
So I'm just where I'm, yeah.
You know, we've done, Representative McNamara and I already did the juvenile justice reform thing. And we got the money for a statewide JDAI.
Yeah.
So, I mean, we've got a lot of pieces that should begin to work. I mean, the pathway into incarceration should be
I think it's
getting chopped off.
Well, one of your- some of-
It's always coming. Yes. It's all the legislators that aren't here. Oh, there she is.
Well, I know Victoria was at the DNC. So. We don't have we won't take. We can give a few minutes.
We talk about the underlying.
Hey.
Hi, how are you?
Good.
Deep enough, but how deep do you look? Do you look in
Sorry.
maternal health?
Well, so I think you can really easily just.
Well, I mean, as an individual that works in public health, that's the route I work on every day. A healthy baby.
100%. No, there's an entire policy.
Half an hour, you're right.
Really, okay.
I mean, some states are doing better.
Yeah, it's
Young children.
It's so funny because I'm an IT guy. Wife's whole side of the family.
Is there an appetite for that? And the
So you see how that played out with both my kids, but.
Maybe.
Well, I mean, yeah, because they're investing in public health.
But that would be the appetite.
It's like a nice.
Yeah. I did a bill on neonatal apps. Several years ago.
Yeah.
I'm starting to forget all the bills I carry.
Yeah, I mean, you carry the max every single year.
I was trying to put together something for campaign purpose. But like bills, this is health related, this is mental health related, this is
I'm right.
criminal justice.
Is there something like that?
She got it, she did, and she's got her best friend.
Thankfully, a lot.
Yes,
Cause she has the change.
yes.
Can she hear us?
Yes.
Okay, could you talk? Just ask that real quick.
Morning.
Okay. Great. Okay. All right, we can get started. Are we streaming?
Yes.
All right, well, good morning, commission members and folks watching at home. My name is Jay Chaudhary. I'm the chair of the Indiana Behavioral Health Commission, and I'd like to welcome you to what's hopefully our last meeting of this edition. I don't know if it will be, we'll find out. So before we jump into to the substance of our meeting, all the commission members received the minutes from last time. Are there any comments or edits to those minutes? Can I get a motion to approve?
So moved.
All in favor?
Aye.
Okay, motion passes. All right, so the only agenda item, which is a big one, but it's one agenda item today, is to go over the draft report. So last meeting, for folks that weren't watching, we approved kind of in broad strokes the content of the report. And then our team has been working along with a lot of commission members has been working to turn that into a draft report. And so that was sent out to commission members and people have it in front of them right now today. Before we jump into sort of a section by section review, we got one request to add something that was not voted on last time. And this came from Representative Ledbetter, who was here virtually. And so before I turn it over to her to make her case for what to add, it's in the workforce section, and it's so many folks are familiar with the Bowen Center's playbook. Many people participated in that, and so you'll notice we sort of incorporated the whole thing by reference, like in this report, saying, you know, this is something legislators should look at when you're making decisions, and then we called out a couple specific things to highlight. The Representative Ledbetter would like to add another specific thing from that report to our report, and so I'll turn it over to her to kind of say what that is and open up for discussion then. So Representative Ledbetter.
Good morning, everybody. Thank you for the Zoom attendance. The Bowen report recommends tax credits for preceptors or clinical supervisors to help improve workforce because there's a shortage of those. And I would like the committee to consider taking a vote on that to add that to this recommendation from the commission.
Any discussion or questions or comments?
I will make a motion to approve that. Plan.
Second.
All right, all in favor?
Aye.
Opposed? All right.
Thank you.
Okay.
I appreciate everyone.
Absolutely. Thank you for raising that up. We all agree that sort of supervision is a major gap right now in the system. So, all right. So, probably no great way to do this, but we're just gonna kind of screen share and go. We'll start at the beginning of the actual substance. You know, what I'll say is I think that there is still a little bit of work to be done, sort of stylistically, proofreading, edits, formatting, probably add a little bit more visual flair to the report. But so if we could focus more on the content today, that would be great. Obviously, we'll probably enlist several of you to proofread before this ends up going to its final thing. So move to sort of part one, the foundations part. Like we talked about last time, I think that the headline of last session was the crisis response system in CCBHC. You know, kind of go through some of the progress made. I think we'll update this data kind of as much as we are able to before publishing, and then we'll sort of make a note about when that data is updated as of in the final report. I think at some point we just got to hit publish and it'll be static, but you know, we're getting kind of new data every single day. So you know, we'll see what happens there. I did want to highlight this kind of hot off the presses data about mobile crisis teams. The first half of 2024, we're still validating some of this data. But if you look at the number of responses, you know, well over 3,000, and then less than one, this is on page 10. Less than 1% escalated to law enforcement, less than 10% escalated to emergency departments. So we were talking before about, you know, the criminal justice intersections here. And, you know, we had an event on Tuesday where we had a couple of sheriffs with more mature mobile crisis teams in their counties talking about how this has had a dramatic impact on their field operations and their jail population. So, you know, I think that's in the long term as we look at some of the biggest challenges facing our counties and local law enforcement. You know, we have early indications that you know, this crisis response system is going to be a longer term solution to some of that. So, and then moving on to see, I just wanted to open up for discussion here in a second. So I think it's important to look at sort of CCBHC is I will say, again, I've said this many times, and we're dealing with this right now, is a massive lift. The difference between CMHCs and CCBHCs in terms of sort of transparency and data reporting requirements and you know, kind of whole, you know, just whole person care and metrics is massive. And as importantly, the difference at the state level in terms of our responsibility to oversee and report on CCBHCs versus what we do now, which is basically nothing to the federal government, is massive. You know, and so we had our demonstration is covering about 40% of the state right now. And that's, I think, a really good place to be, a really good place to start, because it's enough to where we can start to figure out, you know, what's working and what's not, but it's not so much that, you know, we'll be overwhelmed by it. And we've started talking much more in terms of percentage of the state covered versus sites, because I think that that's really the metric that matters, is the percentage of the state that receive these services. In our kind of financial projections, which is what I want to get to, you know, we projected a doubling of that footprint over the next biennium. You know, I'm open to sort of being a little bit more aggressive there, sort of suggesting maybe in a range 80 to 100%. But the financial projections are for 80%. Just kind of given that and projecting this is, again, I don't want to get into the weeds of it, but I can if you want me to. The financial projection here involves projecting what it's going to cost to deliver the right type of care to all of the potential people in a CCBHC's footprint. So there's a lot of projection and speculation involved. And so this is going to be sort of a consistent, constant process of refinement and re-looking at it. And the nice thing is CCBHC allows us to do that in a way that no other model does. We can look at that data quarterly, in the middle of the year, and at the end of the year, we can rebase those rates based on what we're actually getting costs for. So this is a really long-term, constant process of sort of refinement and improvement. And so anyway, I will shut up now. I guess one last thing, I promise. So as far as the funding needed, these are estimates, right? I think that's really important to remember. I mean, I think but they're estimates based on sort of a lot of really intensive work and data from, you know, our pilot sites and our team at the state. So I think, and I'm open to feedback on sort of like how hedged this is and how hedged it should be. I think it needs to be hedged a little bit, because I think if we come out and say a really sort of specific number and are really confident about it, and that number ends up changing during the middle of next session, then that's not a great look for anybody involved. At the same time, if we're too broad, you know, then it stops being really helpful. So that's the first section. I'll open it up to kind of comments and discussion on the first section.
Jay, the only thing that I would comment, and I'd leave it up to your draftsmanship, but like I would leave the numbers the same. I understand the financial numbers. There's logic to that, but if we could have somewhere in the narrative or whatever that the goal is 100% coverage,
Yes.
and then however you want to say that, but then just leave the financial piece the same. And then, like you said, it's an estimate, may actually be right anyway.
It could be right, it could be higher. Also, it also could be lower. And that's the other, I think that's where I don't even know how to deal with that fact, but other states' experiences have been all over the board, where they had estimates that came in and ended up reducing their costs significantly, and some of them ended up having higher costs. But yeah, I'm fully on board, and we can make a note of like, how do we add in narratively that, you know, obviously the goal is 100% coverage. And I think part of this too is if you think about this as like a tipping point, right? Once you get to 80%, you know, we think 85%, the whole system will sort of tip over to full coverage. So I'll put that in there for sure.
Is there any way to model? If we reach that level, what the potential savings are?
So
we can kind of
this is
argue.
where we have, I mean, we have like the dimensions of savings, right? Like we'll have, I mean, from other states, we've had experiences of sort of reduced ER usage, reduced inpatient usage, reduced law enforcement encounters are kind of the big ones. And we have a team of evaluators who are kind of teed up to look at that sort of in real time for Indiana. I mean, and I'm open to suggestions, but just from like a being honest about this standpoint, which I think is important, like I don't know how to come up with a number there. But if somebody does, I'm open to that.
So I've been arguing for the last several sessions. This is a pay me now or pay me later scenario, and you're not going to like the later. And so if there's any way to quantify, you know, yes, we're asking for more money, but we believe, and the modeling shows that long-term, this is going to be a net gain or net savings.
So that's where maybe that mobile crisis data comes in, right? I mean,
so if you take the two sheriffs we talked to, and you say we were getting 20% entry into the jail, we're now getting 1%. You can kind of figure that out, that's a pretty substantial impact to that geographic area. So I'm just trying to think of ways to give me an effective argument.
Right.
No, I agree. And I told Jay last night that, at least in my opinion, in terms of framing this argument, it's not that we have a problem that we need to solve and we need money for it. It's we are providing the solution for everybody else's problem. And whether or not it's criminal justice or ER visits or kids in the schools or whatever, we are right. And those all cost money, and we're here to help you. And here's the solution.
Yeah, I mean, on Wednesday, having sat at the Medicaid Advisory Committee meeting, there is evidence of these upstream approach investments that are cost saving down. And I think it's just going to be able to take the time to kind of extrapolate some of that. But I do see some promising numbers. And, you know, that was really clear to me.
Maybe that's something LSA could do is they would come to you.
Yeah, I mean, I think that the we have other state information like there's a lot of it, right? I mean, from a diversity of states, right? I mean, Missouri, Oklahoma, Michigan, you know, and so and that National Council has that information. We have that. They've done it. I mean, there's a pretty robust national report in 2024, which we kind of allude to here, which has, I believe, a cost saving section, right?
They do.
We could very easily port some of that over. The question I have for you all legislatively is how far does that get us in those rooms that other states have?
I mean, it's just another argument that we need to do this.
Yeah, I mean, we can make the National Council report an appendix to this. I mean, the whole thing an appendix to this thing.
The base argument is we're serving our population in a way that's appropriate. But I mean, when you get down to the final votes and things, people are looking for, okay, I'm going to vote on this. What can I tell the people in my district that this does?
Yeah. And I think that I was talking to some other my colleagues in other states about this, and so the issue we're all running into, this is not just even the mental, this is sort of public health, human services in general, is that like the ROI is theoretical and speculative, right? We think it's real and it's been proven other places, but the appropriations are happening right now, right? And so you know, how to best kind of like tease that, like, we think that this will have a massive impact on our finances, but like, there's so much projection involved, like so much. I mean, it's not even, you know, it's especially CCBHC because it's such a drastic change across the board, like, you know,
So can I ask if we made the council report an appendix, could we then, or at least the cost saving chapter, could we then incorporate within the text of the document? If there's like, I think I've seen it, but I'm not remembering. If there's a summary page and maybe a box
There
like
is.
our recommendations,
Yeah.
so that legislators would see that and be beaming, and then we'd have the appendix if they wanted to actually read the whole thing.
There's the Indiana specific impact page, but the issue and the differentiation, which I think the commission also needs to call out, is that we have federal CCBHC grant funded, we have state accredited grant funded, we have bridge funding. And so the majority of my members, even though there's 8 on the demonstration, they are delivering CCBHC services. And so it's almost like a visual of here's who's federal and what the delivery outcomes are. Here who's state and what the delivery outcomes are. So then they know that those service standards are, because I don't think that's one of my concerns from a provider lens. While I agree with you, CCBHC is a heavy lift, especially from a state standpoint. From a provider standpoint, we have been receiving federal funds for CCBHC long before the state got behind CCBHC. So I have members like Aspire, such in the room, who has been delivering on CCBHC because of a federal grant, right? So how do we account for some of those outcomes and some of those success stories to say, we can't live this on a grant, we need that sustainable source. It's more than just the aid. It's a 24 community mental health system.
sure. But what I will say again is that the data is a mess,
Yeah,
right? Like,
Yeah.
and that's not anybody's fault. Like, this is really complicated, like that, like.
so many pathways.
There's so many pathways, there's so
Right.
many reporting pathways, there's different centers do things differently because the grants that from with SAMHSA are different.
Correct.
And so when you have messy data, to me, putting messy data in a report is worse than not putting it.
Yeah.
Or maybe people disagree, but the data is so messy, it does not tell a story in the way that the CCBHC data will tell a story in 2 years,
2027.
right? Because it's going to be, and later we talk about what those measures are. I mean, there's 21 specific and 4 priority measures that will be consistently collected across the whole state. Because we have to, it's a requirement of the demonstration that we have to collect that data across the whole state. Or at least across our pilot sites, which cover urban, rural, suburban, racially diverse, like the whole kind of gamut of different populations. That data will tell you exactly how it's going. Like in a way that makes sense. The data we have right now, and trust me, I get on my team about this, but what I asked them, like, what can we take out of this data? And like the data is such a mess that it's hard to. So that's where I don't know how to thread that needle, but like, I mean, because from your perspective or legislative perspective, like, I feel like it gets real confusing real fast when you throw.
I just need a simple argument.
Yeah, right. So the simple argument might be, can you extrapolate from this mobile crisis data as sort of an example of how this is reducing the burden on emergency rooms, which healthcare costs are going to be a huge part of next session.
So that's an immediate
Yeah,
example.
yes,
And also
98.
jails.
Right.
in jails.
Yeah.
Crisis.
It's more than that too, right? If you're not in jail, you're going to work. So you're part of the workforce and your kids aren't in foster care.
Yes.
because They have to go to foster care, but you're not available because you're in the hospital, you're in jail. So there's a cost that have to somehow be included in this because they're significant.
Yeah.
For all of us.
Can we tell that hypothetical story of John Smith?
Oh, yeah, we have
Yep.
a pretty good hypothetical. His name's David though, but
Okay.
hypothetical guy.
David Jones.
Not David Reed.
I think.
It might be implied, but I mean, we do have, I mean, and actually the folks back there are some of the ones that actually made up the slide, this sort of David's journey before and after the system, which might be helpful, because then I think if you,
Yeah.
that's people have
So
definitely reacted strongly to that story.
Because we all know a David.
Yes. So we can include a version of David's journey. Which tells, I think, what it was before, right? Where these paths almost inevitably end up jail and emergency room and then go.
We kind of did that in the first report.
Yeah, I
with
remember
people's
that.
case study.
Yeah,
Mhm.
yeah. So we can, and the David's journey is based on a composite of actual stories, basically. So, but it's all kind of wrapped into one. We can change the name, David.
That's totally fine. You can-
Well, I understand a story is relational and it's impactful, but to Senator Kreider's comments, how do we attach that to a dollar figure of an investment?
Jay, can you hear me?
Yes.
Well, why don't we take the reduction in the percentage of the amount of people that are incarcerated and use the total cost of what it would cost to incarcerate those people and use that financial number? Am I making sense?
Yeah, that makes sense.
Right.
What we don't have is a good denominator, but we can ask, I guess, Cass and Vanderburg if they have something there. Although Vanderburg is tough because they still have jail overcrowding
Inmates all
all over the place. Yeah, yeah. But Cass might be the one to extrapolate from because they've been doing mobile crisis the longest.
Yeah. Yeah, just take that reduction and, put a number on it to what it costs to house those, inmates and move in that direction.
So we did look for net with and consult some experts on like, is there a way to put a dollar amount onto law enforcement diversion or ED diversion? There's not a great way to do it. Like there's not really validated or peer reviewed or like quality measures, but there are some measures where you can roughly say that like, I don't remember off the top of my head, but like an ER visit, ended up costing like $2,500. So if you were to then sort of speculate that a lot of these folks, I mean, you have to make a lot of assumptions, but maybe that's okay. Like you can assume that half these folks would have gone to the emergency room. They were diverted. That would have cost $2,500 a pop. Multiply it.
Yeah.
And then you have like a rough, it's extraordinarily rough. Like it's not,
There's so many variables.
right. There's so many variables, which is why I don't, again, I'm fully on board with this. We try to do it even, but like, we have this sort of evaluation team that will do this really, really well moving forward. If you all are okay with like an extraordinarily rough estimate that is like not scientifically valid whatsoever, but is maybe an illustration of, right?
maybe we can just say that we believe there are substantial cost savings.
Sure. Make that explicit in the mobile crisis data.
Preliminary evidence.
Yeah. Yeah. It's not even.
So it's really
evidence.
hard, like in
Preliminary
law
projections.
enforcement,
Yeah.
it's really hard to quantify or to track a positive encounter when something goes right.
Right.
Yeah.
That's a great.
You only report on things that go wrong
Right.
typically, right? And so, and that's the world I came from. And so it's really, you're not going to sit down right out of incident, contact with a citizen when everything went, okay, we resolved this crisis and everything went well, right? Because cops don't like to do research, right?
And extra paperwork.
Extra paperwork. And so that's the hard thing is as things turn in a better direction, the number of people incarcerated go down, but you really don't know how many people were impacted in a positive way.
So maybe we could pull out like with this mobile crisis data, pull out like almost like maybe we can make it even like an envelope, the back of an envelope, right? Visually.
Yeah.
Right. And say like back of the envelope calculation and projection and like hedge the hell out of it. Like this is like,
So this can prove you
but
right.
it's just an example of like what we think this could do from an impact standpoint. That I think that's the best we can do. I don't know if anybody has.
Another state who has done a good job around this is Texas. I don't know if you guys have reached out to them, but that could be a good resource. And then also, I think we need to get total. There's no real consistency within law enforcement reporting data to providers and providers and vice versa. There's a disconnect there. And so we need to be able to shore some of those things up too for that.
And we figured almost all that. So we have a mobile crisis dashboard that is in beta right now. It's probably 70% of the way done. And the exactly what you mentioned is the reason it's not fully done, is that there's sort of like little discrepancies at every single point. But we're working through those. We hope it's public before this report is published, and we can put a link in the report to it. So that will be like real-time data that shows like number of runs, where they are, diversions from ER, diversions from law enforcement. So that will be, I think again, maybe I'm cursing myself here, but I think next session you will have that available for sure. To say like, this is a link to what's happening right now in real time.
So is it too simplistic? And I'm just trying to build on what we've done in the past. Is it too simplistic to take the savings or cost number from the IU study, divide it by the number of people to come up with a per person cost savings, and then multiply it by the number of people that be served in CCBHCs?
Makes sense to me.
That 4.2 billion number
Mhm.
divided by the number of people in Indiana. Sounds like you're volunteering to do some math here.
Well, I think it'd be an easy algebraic equation,
Wait.
but as long as that, I'm just trying to be consistent, you know, like we said, that was the number last commission report. So then can we just take that number and apply it to what we're doing this commission report?
So I will take on the back of the envelope mobile crisis piece of this thing. Our team, we'll figure it out. We're gonna make it a literal back of an envelope, I think. I really like that. So I'm gonna do that for sure.
I think we call Steve's model the keep it simple model.
Yeah. And then Steve is volunteering to do this simple algebraic equation. You know,
You gave me a hint.
yeah. I became a lawyer to avoid math. So,
I went to Purdue, what can I say?
well, yeah. He's an engineer. I mean, you should tap into some of them maybe.
There you go.
I mean, and so Purdue, I think, is part of our evaluation team. So it's like Notre Dame, Purdue, and IU. So sort of like the, you know, not insulting anybody, but the three finest institutions in the state, you know, are all part of this. I think Butler is too, actually. So could be a lot.
Can I say the quiet part out loud?
Yeah.
Just briefly. I just want to make sure that because we're going to hit recommendation 1 so hard, that recommendation 2 doesn't get belittled, overlooked, or discarded.
Oh, yeah.
Yeah.
No, we're almost done, I think.
Okay.
Yeah.
Oh, yeah. I just want to make sure as we're telling the story that we can talk about too, like having a sustainable stream and
Absolutely.
definitely would have it even
Absolutely.
more.
Yeah, 100%. I think we're almost sort of done here. I mean, maybe I'm wrong.
I guess if I could be the voice of the provider real
Sure.
quick. So what I worry about this report from a provider lens is currently within statute, we have a community mental health system that provides services to all 92 counties. Stating in here that we will have less coverage than what we already do is confusing, I think, to legislature. I've heard that from folks. And really the issue and the core crux of the issue is that the funding and the breakdown of the continuum of services within those 92 counties as a result is the issue. CCBHC is that opportunity to fix it. And so why we're not building on our 92 county system of having designated services and already a safety net there versus readjusting some of these numbers to not give us that 100% coverage doesn't fully paint what we're doing currently for the 300,000 Hoosiers that system serves today. So if there's a way we could accurately show we have this group here, we have this group here federally, and we have this group here as a result of the state transformation, we will have everyone on that same path versus people falling through silos because of grants.
So like 3 maps instead of one.
Yes, yeah, like I don't think this really gives the full picture of our provider system and the full needs of our provider system. And I just don't want to get to 2027 and still have a huge gap, a huge hole in our infrastructure because we're not building it right in this report to begin with.
I agree with that. I think like I love a 3-map visual with the ending map being 100% of the state covers. Yeah.
Sure, so we don't have financial projections for that. Just-
What?
We don't have financial projections for that. I'm just gonna say it as plainly as I can. So that's gonna be the first thing they ask is, you've projected this, what's that gonna cost you?
Right, that's what I've been asked, yeah.
So, you know, in my mind, and this is, again, we can put it out there, Zoe, like, this is okay. We've talked about this before behind the scenes, put it out there. That 80 to 100% sort of shift, I think will more than likely just occur once you get to 80%. Like, I think there is, there's going to be, I think, some creative arrangements between existing providers that will end up making that shift happen. Right. And I think, in our mind, under the demonstration, the biggest lift and the thing we're asking of the 2025 General Assembly. So this is one budget session at a time kind of approach. The thing we're asking of the 2025 General Assembly is help us double our footprint in the next biennium. I think you start to go beyond that. I think some of these numbers become a little scarier for these purposes. So,
But I guess Senator Kreider and Representative Wilburn, if we know as a commission to get 100% of our counties covered, right? I'm not even talking from a provider lens. I'm talking about county coverage. So all 92 counties, and we know what that cost is going to be. Why do we not advocate for that cost? And then we land amongst the 80 versus we go in for the 80 and we land amongst the 60. I guess legislatively, that's where as an advocate for access, why would we not ask for 100% of Indiana?
because, again, maybe this is where the disconnect is, because I think the next biennium starts July 1st, 2027, after that, the one after this,
Right.
right? The 2027 legislative session is when the appropriations, or whatever form it takes, for full coverage will need to be hashed out, right? So you have to, so maybe that needs to be more clarified.
I think that needs
So
to be
like
more
have
clarified.
that discussion, make it explicit, the 20, and we kind of say that here, but I think maybe make it more
I
explicit.
think that needs to be that is our
that
vision.
and then sort of decide in the 2027 legislative session how to get to 100% very quickly into the next biennium.
I guess if we could also, I'm thinking there's significant change that's happening from now until then. And if we don't call out what that recommendation is going to be as a group today, we could lose it tomorrow.
So
That's
I
what I
think that
think.
this is maybe a recommendation for the 2027 General Assembly. There will be a behavioral health commission report between now and then, but that's, that can kind of reiterate it, but like the 2027 General Assembly should take the data, take the fiscal quality cost savings data and, essentially appropriate enough fund or I guess we use the word appropriate, but we're also pushing for other sources,
Right.
appropriate enough funding to expand coverage to 100% statewide. Because that's my main focus is the 25 assembly, because that's next, and nothing happens at 27 without 25 happening.
Right.
But
I think
I
some
would-
of that discussion will be made easier if we get some long-term sustainable funding method approved during
Right.
this session.
Yeah.
Right?
And I guess that's maybe, Jay, where you and I are differing on this. I'm visioning this for 2027. Because even though, yes, we have that budget session, shouldn't we shoot for what our end goal is and then put in what it is to be able to get there? Because if the end goal, we just walk away with an 80% system, we still have Hoosiers with unmet needs to meet, right? And so I just know Senator Kreider, going back to the initial Behavioral Health Commission and initial Senate Bill 1, the vision of this all along was for every Hoosier to receive access to high quality mental health. And so I don't want to be short-sighted. I want to have that vision of every Hoosier having that care and access.
I
So
think-
what if, go ahead.
Sorry, I think this, in my legislative mind, the strategy towards progress would be like a prudent approach to progress, right?
Mhm.
Where I hear
Yes.
Jay's messaging about here's the long-term vision, but I hear yours about. So I think we have to make it very clear that this is not end game, but there are certain tools that can get us there faster.
Yes.
Like sustainable funding, and we can make a case that we're reaching for this. We
Mhm.
understand this might be unlikely, but however, here are some things that can actually get us to 85%, 90%, so that in 27, we still don't have a remaining 20% to figure out how to fund.
Yes.
That
I was
makes
gonna- I was
sense.
gonna say a variation on that idea. If we put language in the text of the document about where we want to go from 27 on to get to the 100%. And then our plan is to extend the commission, right? So we could have as one of the charges of the new commission is to get to 100%. Then that, I feel like that would tie it all together.
So two things that I think probably analyze and report on probably fiscal progress, cost saving, all that stuff, right? And then sort of clear roadmap for the 27 assembly
Yes.
to get to 100%,
Strategy.
Yeah.
right? Because
Fine.
Because I could see some legislators being like, I'm tired of talking about funding mental health.
Yeah.
We've talked about this for, and so we have to make sure that it's in front of every legislator's mind that this is the long-term vision, and we're very close to reaching that long-term vision. We cannot yet give up. We got to keep putting gas in the tank.
so that would be the 2026 BHC report.
And I agree with you. But there are some legislators that are very responsive to a plan with a timeline, and then you break up the budget cycles
Yeah.
into pieces, manageable pieces, and I know the DD world did a version of that. So I think like there's a way to draft this to do that like meets everybody's needs.
And also, we need to make sure that the Behavioral Health Commission, isn't it supposed to expire in 2025?
So we agreed last
You're
time
gonna-
that
you're
we're
gonna
gonna
take that?
add that extension.
Okay,
so
but I
I'm saying
mean,
that
we
we
need to
Whatever-
make sure it gets.
Whatever legislation I file will have the
till
continuation.
27, okay.
With a
good.
report due
And you
October
don't see
26th.
to of that. being passed. Okay,
No, once we pared the membership down,
yeah,
that argument kind of went away.
even with change and transition, you
right.
think it will still?
Yeah,
go through?
I
Okay.
I don't anticipate that being a
Okay.
problem.
I guess that would be my only other concern is if that did.
I mean, and so initially it gave us the information that we could do Senate Bill 1 from. It's a valuable tool this time, and it's obviously will be a valuable tool
Right,
next time.
absolutely. Yeah, oh, I agree, but I just want to make sure.
And I think if we make one of the purposes of the commission to get to 100%.
Report
And I
document.
think you can put
That's
language
all.
in there that will not placate, but maybe satisfy a little bit some of the Medicaid cost concerns. So you could say like that, the 26 general or Behavioral Health Commission report should, I think, lead with the idea of sort of evaluate, and analyze the impact, fiscal quality access impact of CCBHC.
Yeah.
And then number two, lay out a roadmap for full coverage.
Yep.
And what's needed in the 27 budget.
Depending on how many bills I end up with, it just looks like
Right.
a lot
Mhm.
right now. It could be a separate bill,
Mhm.
but we could throw it in with parity or
Yeah.
one of those other.
Right, we could put it
bills.
in that,
Pretty
right.
easy,
Mhm.
right?
All right, so we'll add that as a recommendation. And make it clear that like the plan is to get to 100%, but I do think, and I feel strongly about this, and this is not just me talking, but this is based on conversations with legislators, with, fiscal leaders, that incremental is the way to go,
Mhm.
especially in light of the Medicaid issue.
Mhm.
Like 100% is, and I hear you, Zoe, about shooting for 100 and then getting 80 versus shooting for 80 and getting 60.
Mhm.
There's a danger in shooting for 100, we don't get anything at all, because there are a lot of hands out next session, including in the healthcare space,
Mhm.
for a lot of additional money. And then you zoom out to human services, you look at childcare, going to carry like a huge, I mean, so there's a lot of really big, hairy things out there. And so if we can distinguish ourselves by saying like, we're not asking for the moon here, we're asking for an incremental logical next step, as opposed to, all of it right now. But then I think signal that the plan is, again, if everything, because all of this, there's a huge subtext, which maybe we should make text here, which is that this all has to go well. Right? This rollout has to do what we say it's going to do. Because if it doesn't, then forget about it. Like if we sit here in 2026 and we have a bunch of expensive systems that aren't doing what we promised they're going to do, then we're not getting any of it, right? So if we can say, we're giving you the assurances that when we come back to you and ask for all of it and ask for essentially perpetual funding to make CCBHC the new model for behavioral healthcare in Indiana, we will have proven that it works in Indiana.
Yeah, and I think we're seeing that we have been very good stewards with our crisis funds and with our mobile. And I think all of that is a visual that, I mean, I think you said that at 4C's opening, right? Like this is an actual thing that you can see as a resource of that. So I think we are having good stewardship. I guess the only other part in this fiscal piece conversation and with CCBHC that I want to make sure is continued is the bridge funding for those who are not part of the demonstration, who have still been delivering services, because crisis, some of those grants are done in February 2025.
So that's baked into the crisis.
It is,
part of
but it is. Okay,
Yeah.
perfect.
That's
Okay.
the other piece of this we can talk about fiscally. That's big. Continuing the crisis work at non-pilot sites is the bulk of the expense.
Great.
In
Okay.
the
I
crisis.
just wanted to
part.
make sure that, yeah, because I
And
want
then
that to
along with the
continue.
988 call center,
Okay.
which has no sort of dedicated. fund.
Perfect. Okay.
And you can sort of see it if you zoom, and Resident Wilburn will move on quickly, but I just wanted to sort of, can you zoom out to the financial roadmap, that kind of visual, the funding today, next biennium transition period, and then long term. Wanted to sort of, so next biennium, what we're asking for is crisis services at CMHCs, and then separately asking for the pilot sites.
Mhm.
So, and then eventually, long term, the vast majority of the mobile and CRSS will be under
Will be-
CCBHC. There still may be a need for, specialty teams here and there. But I think in the 988 call center, but that's I think that to answer your question. So I mean, there will be, again, if we get this from the legislature, there will be a significant amount of funding going towards continuing that crisis work, in particular at the non-pilots.
The only change suggestion I had in the long term is there's still quite a bit of services outside of CCBHC that is going to still need some level of CMHC or DCS funding for all of those services, whether it be RAP, group home, quite a bit that won't be looped into CCBHC. So I don't know if it's a fair thing to just say CCBHC will be it. We would like it to be the majority, but there's still going to be a gap there, right, of services outside of the.
Non-outpatient.
Yes.
Yeah.
Yeah. Residential, inpatient hospital, psych, depending on how half works out. There's a couple other things that are not included in those 9 core services that I just would hate to lose out on, service wise, for those we serve. So if I don't know the best way to frame that, but.
All right, any other comments on?
Jay, can I say something kind of back up a little bit?
Sure.
The University of Chicago in 2021 released a mental health cost calculator that said the return for every dollar invested in mental health was a $4 return. I don't know if you'd be comfortable in using that for your ROI, but that might be a number that would have some evidence behind it.
Sure, yeah.
Send you that link.
Yeah, no, I mean, I see these types of numbers a lot.
Mhm. Typically is $4 to $5 for every dollar invested.
I believe it. I believe it for sure. I don't know, Sarah Kreider, I mean, what are your thoughts about numbers like that? How do they play?
They might be okay in a bullet point on a one pager or something, but I want to keep this messaging as simple as I can. And so I'm certainly willing to use those as handouts and say, hey, if you have questions, here's a place to go look. I don't know. I mean, it's up to you what.
Sure. Well, I think that I thank you for sharing that. I think that might be something that's more of a talking point.
Right.
And
Somebody questioned. you
like an
at the
aid as opposed, because
microphone,
I
"Hey, where do
think
you
going,
get these numbers?" Well,
we're really
here's
Indiana
a
focused
report.
here, and we'll see what we come up with. If we need something else to kind of bring,
That number was very important for the expansion of broadband. And if we can, have a talking point that we're all on board with, to have an ROI number in sharing to try to move this, I think it'll be beneficial.
I guess there's no harm in including it as an example.
Right.
Right, and say our group will do something similar for Indiana. So I think that's one of the, we have healthcare economists on our evaluation team who are tasked with exactly that, like figuring out like, what is this ROI, like in its most simplest form.
Did they use a number like that for broadband? Like, did the governor's office use that?
Yes, there was a number out there. Yes.
So if it's good enough.
Send that link over. I think we can include it and, sort of, because it sounds like we need like an additional paragraph, probably in conjunction with this mobile crisis data, to say that like this sort of maybe something to the extent of like this just scratches the surface of the potential cost savings, for example, and you could use that Chicago number, and maybe something from another state with CCBHC. As sort of, again, more as examples as opposed to saying this is going to happen here. Because I think that the danger is saying this will happen here, but we can say that we have reason to believe it. This will happen here.
Yeah, I agree. And I apologize. I had a scheduling error at home. I'm going to have to leave the meeting. I'm really disappointed. I'm not going to be able to continue, but thank you. Okay.
Thank you.
Thank you.
Yeah.
All right. Well,
We'll be in touch.
Okay. Thank you.
okay. Anything else on section 1A? Yes.
I guess the only other thing, and we can discuss, I would like to discuss with Kelly, and you, is I want to be really careful about putting anything forward on the property tax levy, until we know through demonstration and the no wrong door approach, how that's going to impact our local communities. Because we don't know if that's something we're still going to need or not to help and service through no wrong door, because it's Medicaid. And right now, Medicare is not even a provider type. So there's a lot of lives that we're still seeing within those communities that property tax levy dollar might be able to support. So I don't know if we're ready to like go live with that statement yet. So that's just a concern that I have.
Kelly, any thoughts on? That's why you're here.
Right. I hear what you're saying, but
Mhm.
where specifically are you?
On page.
On that visual,
18.
on
On
page-
the visual where it says property tax levy paid from Indiana counties to CMHCs, and then property tax levy varies per county, and as Indiana transitions to CCBHC, the
Yeah.
funding will gradually be repurposed. I just don't know if we're ready to publicly go there yet. Because the demonstration is really going to determine what those needs are. It could be next budget session where that gets talked about. I don't know if we're ready to put that publicly out there.
I wouldn't disagree. It implies something that could be expected.
Mhm.
So we
which
can-
would
we
then
can
call
limit
for
that,
analysis.
we can limit that just to SMI appropriation, because that is happening with the pilot sites, like repurposing what we can that's currently going towards MRO match for CCBs.
Mhm, right.
And that's actually crucial to this argument with state budget and also the fiscal leadership, that like, we're not asking for all of this on top of what we already get. We're gonna
Right.
take what we already get, use it, and then ask for what we need on top of it, right?
Right.
And so we can make it clear that we're only talking about the SMI appropriation. We can get rid of the property tax levy piece of this, but it is part of the way the system is currently funded.
Mhm.
We can sort of say to be determined or something.
Yeah, I think we just don't know that yet
Okay.
with, especially with the no wrong door approach and only Medicaid supported for crisis and CCBHC. There's a lot of, then that's going to increase a lot of unfunded care, and that won't be sustainable, and we'll be right back in the same boat that we're in today.
All right, we can make it clear that the only part that's right now that's being repurposed is the SMI appropriation. Because we also don't want to lose that,
Thanks, Kelly.
right? So
Right.
we
Mhm.
need to make clear that's gonna be repurposed, and we can. I guess we can get rid of the property tax levy piece of it, because that's not a state appropriation, so it's not really helpful in this situation.
Mhm. Thank you.
All right, anything else? Last chance on this section. All right, I think the rest of it will go quicker, but I don't know. So moving on to the kind of, I think the other big piece of this is the non-CMHC, CCBHC piece of the system, which I think is really important. I think it has a really big impact. We talked about, ensure that, they continue the planned work to review Medicaid rates, and just make sure that continues. Anything on the Medicaid rate matrix section? Pretty short and sweet. Okay, moving on to parity. This is language that Steve got from Mental Health America National. Steve, you want to say anything about it, or speak for itself for us?
I mean, I think we discussed the concept before. It's a response from both what Cindy had, and then also the testimony from IU Hospital, which I'm not remembering his name. Right. Try to respond to the idea that we have a lower reimbursement rate oftentimes for people, professionals, providers with mental health expertise. And that's oftentimes a result of the system where the reimbursement rates are lower. So basically, this says parity should apply to provider reimbursement as well, and tries to tie it as a marker to the Medicare rate. Basically says, if you waiver outside the guidelines of 10% of the Medicare rate, then the Department of Insurance is to take a look at it. And that doesn't mean that they will necessarily rule in your favor, but at least that's the trigger for them to take a look at it. And that seems like a logical approach to me, where it's not like a mandate. And then Representative Ledbetter had the issue of if you if you have an insurance provider for services that contracts with a third-party vendor for behavioral health, they aren't necessarily bound by the parity statute, which seems ridiculous to me. And so this basically would say that they are.
And we took a run at parity
Yeah.
once before, and I ended up very frustrated at the end of that. So we're gonna try again.
I had one question, Steve, about the Medicare rate.
Yeah.
Are there services that are not, there's no equivalent in Medicare? Like, I was thinking like for children, is there anything that you can't make equivalents?
I mean, equivalence is in the eye of the beholder, right? That's where parity becomes difficult for implementation. I mean, I think you can always make a case, and then it's up to the decision makers to whether or not they agree. The federal government has put out, when they passed parity, it seemed like logical and easy. But then it turned out to be hard and difficult and very dependent on the details. And so CMS has put together a lot of regulations with regard to parity, and actually they're going to be, well, we'll see what happens, I guess, with the election, but the plan was that there would be more with the current administration. And I think what we talked about last time, and you sort of incorporate the idea that it'd be nice if the Department of Insurance would take a role here. And sometimes you do need a referee that calls balls and strikes. And so I think that's important.
Sure. Okay, is this the question was mainly, do we think there's a loophole here for an
There's
insurance.
always-
There's always, but is there one here for insurance gonna say, well, there's no equivalent to this child
Yeah,
service?
they'll argue.
Medicare. I don't know what you said about it.
Well, but I think the Department, that's where the.
DOI can come in and say,
Yeah.
no, there is an equivalent here and you're not.
Yeah.
getting it. Yeah, parity's brutal. I mean, it's just it's such a slippery concept
Yep.
and an idea.
But Jay, to your point, maybe we put Medicare rates, but then also the accountability of the youth, because youth was such a need in this.
Maybe
report.
call out like, or we probably words with the language, right? Like,
Yeah.
it's just like
Yeah.
something about youth specifically in there.
Great point.
And I don't know enough about Medicare to know. There may actually not be an issue.
And I'll just say the language from national, sort of a copycat of a statute that passed in New Hampshire. So I'm totally fine with whatever you want to do to tweak it. But, there's also an advantage of copying another.
Oh,
state.
yeah, and there is there is a draft bill that Steve provided in the, which I think is helpful for sure. Anything else on parity? All right, moving on to workforce, so kind of try to divide this up into three sections, right? The first one, I think there was a lot of different recommendations that all fell under the broad category of like leveraging other types of treatment providers. So the first one was Dr. Yoder's consultation, not hers, but I mean, kind of yours, right? Consultation programs. I don't think there's anything really needed to be said here. I think it's a huge no-brainer, easy win for everybody. Especially the risk, or the insurance pooled model. I think that will, again, maybe I'm naive here, but I think that will play well. Next session. Rosemary Wilburn, anything to say about OTs, or have you said it all?
I mean, we've said it all. If you're not convinced now, you'll never be convinced.
The APRN one, I'd like to not talk about it right now, but if we need to, we can. I think we hit it pretty well last time. I made a little comment there. I think I wanted to, just lay out, look, this wasn't unanimous. I think it's important. Any comments on that one?
No.
Okay, thank you.
We tried.
There's no great place to put the first responder training from a structural standpoint, but I put it under here because I think they are part of the workforce, whether we like it or not. And I think our goal long-term is to make them less part of the workforce, but they still are right now. So anything on that one?
The only question I had was,
Sure.
I know we heard about mobile integrated health. Is that being taken up elsewhere?
Yeah, so there will be bills on MIH next time, and last time we kind of decided that it would be a kind of mission creep to put it in, but I think it will be other places. So.
I think it makes sense. The sectioning of continuing the programming and exploring opportunities for new providers to have similar programs.
Absolutely. Residencies, again, I think we all kind of agree, we need more psychiatrists. This is a way to get them, hopefully.
And this is the section I think we include the new preceptor clinical instructor tax credit. as
Oh,
well.
beautiful.
Yeah.
I agree. Good call. And then the last section is kind of the most unwieldy one in some ways, but also I think important. These are some of those like, we put them under the guise of like structural barriers to workforce development. Most of them involve PLA. I was pleasantly surprised to see that, I had sort of, somehow I missed this graph in the playbook, but that we have increased our workforce over the last couple of years. I mean, not a lot, but not insignificantly, especially LCSWs and LMHCs. So that was kind of, maybe that's a sign and from a narrative standpoint, sort of showing, hey, like investment in intention work. And that was one of our requirements from the commission, was the increase in workforce. And so I think we have a good story to tell there.
We've actually seen that in our system. In particular, our overall vacancy rate was improved by 3% and our turnover was also went down as well system-wide. So I think it's the work of CCBHC and a lot of these initiatives.
So
Do we have an idea how many we're lacking though?
Pretty still.
and that's, some of that's in the playbook.
Yeah.
It's way up.
Yeah.
Yeah, some of that's in the.
I'm meeting with them next
Still
week.
pretty bright red.
Yeah, and so yeah, as you can see, I mean, we do reference the playbook quite a bit, I think, we link to it and. I don't know, I mean, this will mostly, we can talk about this, but this will mostly be digital, I think, I think that's the way we're thinking of this, so like links. To things, but if and when we decide to do this, do paper versions of this, we could consider including the playbook as. Because it's, we talk about it so much.
So, because we did this last time, so just as a reminder. One of the things that we thought about last time, and I believe we did, was we did create a paper, like a one pager for
The
the
legislative summary,
legislative.
yeah, that's in the table of contents, it's contemplated, we just have to.
Okay.
Kind of executive summary, legislative summary.
Yeah.
It won't be 1 page, but it'll be like 3. So any issues on these recommendations? Again, these were all talked about, Gina Woodward last time. All right. Let's take a 5-minute break. And then we'll dive into part 3.
Refresh here. Yes, meeting says he will try something.
That's right.
If you like. As well, so I think. Yeah, she is for sure, that's. She's. Like blood. That really is like learning the phone. Yeah. I don't know, I'm a little worried that she seems to be shifting gears a little bit. There. Steps for them. She could do it.
Yeah, I think it's very.
It's good for her hair and stuff.
Yeah, exactly. Yeah.
Thank you.
Sure.
What's your work? Oh, exactly. Good for you. We spent a lot of time. I forget when, years ago, by training in schools, and then they had that cleanup bill. I think they eliminated it today. So. So the issue. It's not the football. See. So you get all. Then my own grandson was at my birth. So. Sorry. And he didn't react, he didn't do it. It was about. But yeah, I think we got to a place there, but it's happy.
Yeah, me too.
We're moving through it now, but. Yeah,
All right, let's jump back in here. Last section, which was our sort of special population section, so. Thanks a ton to a lot of different commission members, for contributing to this. Okay, there we are. So we'll start with children. I think the top line kind of message was like, look, this is a continuum and it needs consistent bolstering everywhere. And then the specific areas are, we tried to fit them in to a graphic. Hopefully that's clear. I don't know, Senator Crichton, that's clear enough for your colleagues.
Yeah, I like that.
We kind of crammed together a couple different ones to try to make one that made sense. Again, the point being, this is again, part of our conversation from before is that like our goal needs to be community-based care, right? It's better for everybody. It's better for children, better for families, better for the system. It's cheaper, it's better. Unfortunately, the situations that get our attention are the ones that may require from time to time more intensive care, which is again, part of the continuing part of the issue, but we need to focus on the external stuff. So anyway, I don't want to ramble about that. David, thank you for your contribution to the I'm not even gonna do the acronym, Children with High Acuity Needs Project. So I almost threw a sentence in there about fix the acronym, but I didn't.
Yeah.
So so we'll continue updating if there's some data here, we'll continue updating it. But anything on this, on the Chan? And then I put a comment there about the residential settings. We had that conversation. I felt obligated to put a comment in there. Any issues with that comment?
We're at Jay for the comment.
What's that?
Where did it come?
It's on page 35. It's in italics. We'll probably have, in the final report, we'll probably have these more separate. The idea being just kind of popping in from time to time to sort of provide some context, but I think it captured our discussion, but all right. Michelle, we've gone to the school framework. We do call it IDOE specifically recommendation. Any issues with that?
No, I mean, I wanted you to call out IDOE because I think it's important to have the school working with FSSA in the department. So no, I think that's good.
The MSC, Dr. Yoder, thank you for connecting us with that group. Do we capture kind of the recommendation and the context?
I think so.
Okay. I did add a note there to the recommendation because I think this is something that gets lost sometimes, that in order to do a state plan amendment or a Medicaid service, you need legislative kind of appropriations and approval. So I just wanted to make sure that was clear. That FSA can't just do it, right? It needs sort of cooperation.
I want to step back just for a moment,
Sure.
back to your comments on residential settings for
Sure.
youth.
Sure.
I read it multiple times yesterday and just sitting here reading it again. You know, I'm at the grassroots in counties of children in need for services for, you know, across the scale, but placement is becoming apparent a bed problem with facilities closing statewide. Counties having to build their own statewide. So I don't know if I agree with that comment. If there are not enough beds or acceptance of children. At what? Do what?
I'm looking at David because I think
I mean, it's
Then I'm
from
talking.
a numbers standpoint, it's not a shortage of beds. Beds are there. It is a shortage of yeses to accept the youth who need those beds. And a lot of challenges with getting the admissions to actually get done because of the acuity of the youth. But I mean, there are beds out there, and I think it's one of the challenges is
Well,
that,
then what's the barrier?
again, it's the acuity of the youth.
it's the
and-
control piece of it, right? So it's like there's no beds so I think you had missed last, so like.
Watch remote.
Yeah, so the discussion we had, and this is where we went down the road of the no reject, and ultimately, I mean, look, I'm open to revisit it, but I think
Yeah.
ultimately as a commission, we decided not to make that. So other states have done things that are called no reject contracts, where it's a significantly higher, like, I mean, double, right? I mean, a much higher rate in exchange for not being able to say no and not being able to eject a child. So on the provider side, the main concerns are that adding a really high acuity youth to a milieu that's not that high acuity can be super disruptive, right? So like, it's almost like in some cases you have to have like separate, almost like a segregated separate, right? Like that's, I mean, yeah, we
Right,
talked about
yeah,
this,
it's not.
yeah.
So-
You explain it, I can't, but.
So just running some
Yeah.
acute units in the past, like. It's not clinically in the best interest then, not only for that kiddo, but then also the kiddos that are on this unit. That it could be more trauma provoking for some of those that are there for, so it's a balance, I think, with that. I agree that we need to come up with something because of the denials and not having enough beds, but is it more of like the long-term care recommendation where the state is working with long-term care and community mental health to do something collaboratively together and not just maybe through like, it won't be one provider to solve some of these high acute needs because they don't have the staff or the workforce.
So these youth with these high acuity needs end up in our judicial.
And judicial,
system
correct.
Of my probation,
Yep.
county probation departments are overran,
Which
so.
is not appropriate either.
And that is why I've recommended we do probably need someone judicial on this commission.
Mhm.
But this is an issue, because these children, okay, so
Yes,
I hear what you're saying, there are beds, but at the same time,
they're not.
So which-
they're at home in their bed with an ankle bracelet.
Which is why I think the real importance is that this work that has been started. Which is sort of cross-agency, DCS, DOE, FSSA, DOC, does not stop when the administration changes, right? Because there is not. There's 2 points about this I think are important. Number one, from a volume standpoint, it's not that high, right? I mean, I think that's like the kiddos that end up backing up into the whole rest of the system from just a pure number standpoint is not that much, but every single one of those 8 cases cause just tremendous problems everywhere else, whether it's schools or
Yes.
juvenile justice and so
Community.
it seems like it's a solvable problem, but it requires what we've been doing, which is that sort of cross systems collaborative case by case approach. And so that's why I think we decided, like, the main point is, look, like, this work that's been started we can't afford to not continue it in the next administration.
Does it say that in this?
Yeah, so that's and then we can make that clear. The recommendation is for us, maybe we should even lay out, like, specifically continue the high acuity. Right.
I think so, and I think also really engaging providers
Right.
too intentionally to make sure they understand the needs of the youth, right? Because I think they want to try to create programming, but we got to make sure they're involved in the conversation as well to figure out
So-
exactly what would help this population of young people.
So, I mean, Kelly, I think, to your point about, like, this is an issue becoming more of an issue. I think that's 100% true, which is why I think this group was convened and needs to continue, but there's not a single, magic wand solution. Including, increasing residential has been tried in other states. Like,
Yes.
they have tried it and it does not fix the problem.
Well, I'm not requesting, we seek a solution.
Yeah.
I just don't want it to be treated as an unknown, with no plan.
Sure.
Because these children are ending up in juvenile detention when they when they have needs of.
Or in DCS offices. I mean, they're ending up in terrible places.
So maybe we could tie in the work of the youth justice work group that I also sit on, that met on Tuesday, that's addressing a lot of the detention, why they're ending up in a detention, because of not having another place, the D&E and that report. Maybe we could reference, because that's probably the biggest thing with state, right? Like, this group doesn't know what that group's doing, and maybe we could thread that needle for some of those recommendations, because that's their main objective, Kelly, and there is probation, public defender, a judge that's leading, and court services that's leading that. So maybe we could tie in the recommendations of that report so that then that gets lifted up. Do you think that that would be
I
helpful?
do, thank you.
Okay, yeah, let's.
So we're gonna have to vote on that. It's a new one. Or it's an addition at least.
Can you add it to your commentary?
I guess that's true. I could just say that there's other groups, including youth, that's the main other one.
That's the main one, yeah.
So like explore other groups that our stakeholders.
Well, yes, that's good. I'll add that to that. And then, from, I guess to the question of the next commission report. Is this particular issue, high acuity youth in particular?
Yeah.
Should that be called out specifically?
Well, I mean, you came to the meeting I have with my school superintendents. It's a big topic amongst the educators who have students who are in Missouri or some other state. So apparently there are other states that have a facility that can take. It's incredibly expensive. And then the regulations around that are really burdensome for the school because the parents want to visit their child and the school's responsible for, transportation out to see their child and so that part of it is something that's a big topic just in the schools that I have in my district.
David, what's your?
I'm just gonna say also, I mean, we've had a number of youth, we've offered really substantial per diems. They don't have the body, like, I mean, I'll pay you for a one-on-one for that child. Well, I don't have someone to assign to that child one-on-one. Their workforce issues also impact their acceptance ability for some of these higher acuity youth. I mean, the dollars alone haven't been able to solve it for some of these really challenging young people.
Doesn't that require a pretty high level of expertise? I mean, it's not.
I mean, you at least need to have some experience managing behavior and de-escalating, youth who can get aggressive. So yeah, proper training, but just having also just the physical person there to do the one-on-one service can be a challenge for a lot of our programs.
I think it's also really tricky defining eligibility for certain youth as well, because even though they might display some similar behaviors, the underlying root problem of why these behaviors exist is often muddy and may not meet criteria. I think the residential portion is just a really sticky widget problem that we need to think through thoughtfully, because youth that are that do end up going to residential settings don't necessarily have better outcomes long-term.
Thank you. I was gonna kind of say that too. I mentioned earlier about for every dollar spent, you get this return. That's not the case for residential or acute settings. I mean, there's no evidence of that. I mean, those are our most expensive treatment options and the return is not positive.
Yeah, and I'm hopeful with some of our other like MST that we'll see
Exactly.
a dropping off of the number of desperate
Yep.
cases.
Yep.
Jay, do you have a ballpark number of what, I know it is a small,
So David, I mean, the rapid response team is staffed about 20 cases.
Probably more than
Yeah.
20.
Yeah.
So 20 to 25 in, a year and a half.
Yep.
But I think what Kelly's
There's a little
saying,
bit more that don't make it to that because
Sure.
because the thing is, if they're in juvenile detention,
yeah,
they're not considered
that's true.
rapid
rapid
response because
response.
they're in a place, right?
Right.
So it's probably significantly more, but that's
Fair.
the. So, okay, so it sounds like there is an appetite for specifically calling out progress in high acuity youth as a specific focus area for the next
And
commission.
collaborations with the judicial
Yeah.
system.
but also maybe even just kids who are in the juvenile system who should not be in the juvenile system because that's the only thing that, so they might not fit the high acuity. It's more because a D&E is needed, the reason for why they got there and what was talked about at that work group on Tuesday. And you highlight this very well in the Children's Mental Health Care Continuum. It's because our care continuum for youth is broken.
Right.
And so until we have the right partial day treatment, respite care, subacute for our youth, until we have that full continuum built out, then juvenile detention is where these kiddos end up. So in addition to MST, it's also that full
So
continuum. of
maybe what the
service.
next commission should do is specifically look at the continuum
The continuum.
with a special emphasis on high acuity juvenile justice youth.
Yes.
How is JDAI?
Yeah.
being
And,
implemented? Is it working as we did it?
Well, and for DCS involved youth that are really high acuity, they've been through our foster care system and we haven't been able to give them a positive experience. I really do feel like intensive foster care, which is included in this, is going to roll out this fall, has the potential to help us reduce the number of youth that end up being super, because they haven't been able to bond or attach, because they've gone through 15 different foster homes, and we know a lot of youth like that. But hopefully this will prevent that outcome for more youth.
Representative McNamara and I passed a pretty significant juvenile justice reform effort a couple of sessions ago. Then we got it funded in the last budget to increase ADAI and require a validated screening tool to try to deflect youth into treatment as appropriate. And so things are happening. It's going to be interesting to see how, only less than half the state was actually using those concepts.
And I'd be really curious the data that you're seeing in your work group there, Zoe, because I mean, for probation involved youth in residential, we are literally at an all-time low. We've never had fewer youth residential, we're on probation in Indiana. And it's significantly lower than we've been in the past. We had over 1,000 not that long ago. We're at 390 today. I mean, so there's been a lot of progress. Now, the ones we have can be really, really challenging to provide good, high quality treatment for. But there has been some return on these investments that have been happening.
So that number you speak of, is that juveniles in detention?
No, they're in
No.
treatment facilities.
Treatment
Those are
facilities.
DCF paid to treatment facilities.
Okay.
So you're on
So-
probation in facilities like that.
What about the numbers
That-
that are not in?
That's what I wanted to ask Zoe about, like from her work group, like what you were seeing for increases in detentions, if you were seeing that.
Yeah, that's the
And-
whole
and to
purpose
what
of,
degree?
that's the whole purpose of the work group. Senator Kreider authored that work group bill. He was one of the authors. So it's because they has seen such an increase of juveniles
Do you have a
within
sense of like
detention.
how large that increase has been?
I don't have the exact percentage in front of me, so I don't want to misquote it, but that's the whole purpose, is to lessen that. And I guess also, Kelly, to your point, and just knowing your perspective too, it's like that full continuum within a rural community and the rural resources, because sometimes all you have is juvenile, right? Because from some of your counties, that rural, so I think we need to pull in, it looks very different in Marion than where it does in your
Yeah.
service area too, for
So
kiddos.
Regional differences in how they utilize
Yes,
their services
right.
across the state. Some
Mhm.
places you think, you
Synthesize
want, you
it.
don't.
Yeah, okay.
Those
So
things
probably-
are-
could we lift up the systems that maybe we should collaborate with? So then the next commission report could kind of highlight that, like
So
the
it's juvenile
youth.
justice.
Yes, JDI, some of
JDI.
this other.
So the note takers, so the systems are JDAI, we could do the acronyms later, JDAI, YJOC, and then the high acuity
High acuity.
work group,
Mhm.
which will have a different name at some point. And then we'll make that, we'll wordsmith it, but essentially like one of the specific things the next commission should focus on is sort of synthesizing and analyzing
That'd be good.
the children's continuum with a specific emphasis on these work groups in conjunction with the work of these other groups. That sound good?
Thank you.
Okay,
I
thank
think
you for
that'll
raising that.
satisfy a lot of people that are concerned.
Yeah, I mean, it's, the thing is, and my last comment on this, I mean, David will attest to that. I mean, it's like every single one of these cases is so incredibly complicated. And probably if you talk about prevention, I mean, the issues go back, and there were probably areas for intervention starting in infancy, right?
Exactly.
And that we failed to intervene in. And so it's really an issue there. Okay. So thank you for raising that, Kelly. I appreciate that.
Thanks.
This next one was Representative Ledbetter. Just, I think it's a good thing, sort of like, again, to the point of equipping families and caregivers. Any comments on that? 3.1E, Zoe, this was, I think was yours for the most part. Any issues with the language we ended up with? Sort of like, look, this is. I mean, this
Yeah, that
is,
was a recommendation
Yeah.
actually from the youth justice
Okay.
worker.
Perfect. And then we have a letter from our youth advisory board coming. It's done. They just wanted to put their emails and signatures, and I think they wanted to put their social media handles on it, so. There. This letter from school superintendents, again, this came out of the meeting, Senator Kreider, that we had. They wanted to sort of write a letter to support our work and lay out that this is not only an issue for you know, criminal justice and DCS, but also for education. So that's a helpful piece there. I don't know how Marlon Jackson got on.
I have a question,
Yeah.
Senator Crider. Do the superintendents like work with anyone like Dr. Jenner or anyone at the DOE? You said that you work or you have like a working group of superintendents that you.
So I just have a monthly breakfast with all the school superintendents in my district. We sit around and talk about pending legislation or
Yeah.
any issues they're having.
Didn't know if they ever like elevated their, concerns to the DOE or if there's been
So-
conversations that I maybe wasn't privy to.
So I think they just have to follow whatever the regulations are and the state law. And when they have a student that happens to reside within their district, sometimes they don't even know that student moved into their district because they're not attending school there, but they're obligated to pay the financials for wherever they end up. And in a couple of circumstances, that was in another state, and the numbers that they gave me are just staggering how much it's costing. So I can tell them to call you next time I meet with them, or call somebody and talk about
Yeah, I mean,
their issues.
I would be interested to hear more.
It's a fun breakfast to go to.
Yeah, it's a good breakfast. if you wanna
About
come.
their concerns and if there's
Yeah.
any,
But that's probably one of the better things that I've done as a legislator. Just sit down and listen to what's happening.
yeah, absolutely.
Great. So last thing, I made a comment on social media. I don't know, it just seemed like I had to talk about it. I didn't want to spend a lot of time on it. We decided not to do anything explicitly on it. I didn't know if it was worth mentioning that we did last session ban phones in schools or during instruction time. Which seems to be catching fire across the country now, that one piece of legislation. So I may throw in a sentence about that, say we ban phones in schools, which most people, I think, other than students, agree with. All right, Jason. It's your time to shine, bud. Thank you. Thank you for your contribution. We really didn't change a whole lot. But you did a great job of laying it out, so. Any comments, questions, concerns
No,
about?
I think it all aligned with kind of what we sent your way. I know you said that this is gonna be like a digital document, so maybe it might be good to include some of these links or links, especially around like the age-friendly health systems. In that regard, and like if we want to link to the long-term scorecard and things of that nature.
Absolutely.
But, and then there's just a little grammatical thing with regard.
Yeah, I mean, well,
I can touch base with you on some of those things, so.
Great.
So in a meeting I had recently with nursing home administrators, they cited a problem where increasingly a person with maybe serious mental illness is getting a diagnosis of early onset dementia or
MCI.
some other challenge, and then being admitted into the nursing home, which typically they go into the memory unit, where they're creating lots of problems.
Yeah. Absolutely. So that's 3.2D, which was Zoe's suggestion, or not Zoe. Zoe drafted most of it. So that is one piece. But the other piece of it we see all the time is even an older adult that's not going to be an issue for a nursing home because of their criminal justice record will be blanket denied admission to a nursing home. So trying to kind of combine those two things into this recommendation, which is that I do think we need probably a couple facilities that focus on older adults with severe mental illness. And I think that I wanted to call out the criminal justice piece of it because that's something that more and more I'm seeing, like this person can't walk, is just completely docile and not really, but because they have, child molestation conviction. It's usually sex offense. They are, sitting in our state hospital at $2,000 a day when they could be in a nursing home getting the vast majority of it paid by the federal government. We probably have 30 of those people in our system.
The only change that I had to that on 3.2D is, it's listed up here in the recommendation, but you definitely want to put in the recommendation in collaboration with skilled nursing providers
Yeah,
and community mental health.
okay.
'Cause
Yeah, the
they're
recommendation itself.
Gonna do it on their own.
So, all right, well,
They're gonna need that mental health support.
And we skipped one backing up.
Yep.
This is the per diem for group homes, you brought up. I think it's timely, I think it's needed. This is a gap in the continuum currently. Anything else, older adults? Good. Last section, most of this came from our honorary commission member, Kelly Hartman. Up here. But, I think this is complicated. This is sort of, again, that short-term, long-term issue, right? Which is like, I think long-term, it'd be great to have like a waiver that gets rid of some of those federal silos with these funds. That's probably a little bit away, just realistically speaking. So I don't think that could be our only recommendation. So we kind of combined them into a two-part recommendation. Number one, kind of building off what Katie Adams Southwestern presented us, was that, CCBHC does allow for some more flexibility. And so, we should make sure that's built into our CCBHC rollout. And then number two, long-term, especially using some of those lessons learned. And maybe appropriating some funding for programs like Southwestern's to learn more lessons. Long-term goal being a waiver that brings that funding together. There's a lot of steps between now and then.
Such timely recommendations, though. I
Yeah,
mean, as Medicaid waiver conversations continue to I just think there's some creative solutions, is what I'm saying.
absolutely. Well, and I think that, again, this is something we don't have time or energy to go into this, but I think a waiver like this would end up generating massive cost savings.
Yes,
And I think you could probably, again, when that work is done, you could build that in. And then our favorite recommendation, change the name of behavioral consultant. I think it's a real small thing that would make a big difference. And then the clinical liaison, I think, kind of a no-brainer. I think it's important to have this priority in statute, right? It's just like suicide prevention is in statute. I think having this in statute. All right.
is
What-
that, sorry, Jay,
Go ahead.
this is something that can be done administratively, yes?
Yeah, it could be
Yeah.
for sure.
Just making sure.
Definitely. So that was one of the things that some of these recommendations are, we tried to make it explicit when it's General Assembly, and then if it could be done either administratively or through statute, left it more broad. And then the last thing was the kind of menu of options for sustainable funding, just like we talked about. And one thing, Kelly, you brought up, and we didn't have numbers on this, but maybe it's worth just adding a sentence about like non-cigarette tobacco
Nicotine product.
nicotine products. So we looked for numbers on that because this cigarette tax has been around forever. So there's lots of numbers out there. What it would generate. I didn't find any numbers on like nicotine products, but we can put a sentence.
Well, it's,
So vape products have a correlating tax attached to them. But I don't know about other.
Well, it's mostly referencing vaping,
Right.
because that is an epidemic, especially with
Particularly among
our youth.
Yeah.
So this is where we need to focus curbing the use of.
So yeah, we'll add a sentence about this, consider all increased taxes on all nicotine products, including vaping, and also like Zyn, like those pouches are like all over TikTok,
Oh,
is my
yeah.
understanding.
Yeah.
We'll add a sentence about other nicotine products.
So I have a suggestion or just kind of
Sure.
concern. So it'd be kind of for our legislature too. So if we are laying out these recommendations within the report, knowing, transition is upon us, would it be better to include this more as an appendix of recommendations versus coming out
In the body.
and stating in the body? I don't want to, I don't know, shoot us in the foot by with putting taxes forward and having those as the recommendation during transition. That's very unlikely. I've heard pretty loud and clear from some folks that that's pretty unlikely. I've, shared those concerns with you. Should we say we need a sustainable source and then have this as more of an appendix of recommendations? It's just a question.
Well, I defer to Senator Kreider and Representative Wilburn on how that. What do you think?
Go ahead, Senator.
My messaging has been, we need long-term sustainable funding, and it needs to be something outside of the Medicaid discussion. And what that looks like will be like last year or last budget, when I presented Senate Bill 1, the House members, they said cigarette tax or alcohol tax, we'll do either one, right?
Right.
So the challenge is on my side as to what folks will agree with.
But so do you, I mean, so the different, as the difference between something in the appendix and the body, I think, is pretty significant. I mean, I think if and that, take your point for sure. Like, if something's in the appendix, I think the chances of it being read, I don't have a scientific number to make up, but like they plummet, I think, pretty significantly. So
I was trying to remember what we did last year, to tell me, or last commission, but I thought we put it in the body. And then as an appendix with the legislative recommendation sheet, we put it in that. So I almost wonder, or at least throw it out for discussion, I would have reformatted this a little bit and say, to me, the lead is we need X amount of money. And then how do we get it? Well, here are options.
sure.
And I think we want X amount of money in the tech and body of it for sure. And then I think it's fine to give options because that's totally voluntary. We're just trying to be helpful. And then if we put it in the appendix, same way with the other legislative recommendations, and legislators can look and they can say, oh, we're going to need this amount of money. These are the different ways to do it. That'd be.
So we can very easily say, because I think that the target number for next biennium is 50 million more in 20.
We talked about this being largely virtual. And when I had brought up the concern about having it, kind of right there at, when we talk about funding way in the beginning here, I think to be hyperlinked to this detail would go a long way. Instead of having it positioned concretely somewhere, right, in the body. Because if I want to learn more, then I want to go learn more. But if that's gonna trigger me to like, I don't want to do any of this because it's increasing taxes, then I can continue to at least read the document.
So we can add a sentence with a hyperlink to the recommendation about money in the first section, right? Say like, and it's already kind of in there. We can make it more explicit, like that.
I think that
We should, generate X amount more either by increasing the CMHF or implementing, one of the sustainable funding sources linked here. So it'll still, that way you kind of have it'll be in the body, but it won't be like front and center in the body of the report. It'll be in the appendix. How does that sound?
Sounds like compromise, I think.
And I think we're assuming, correct, that the 100 million stays and we're building on that.
Yes, we made that.
Do we?
I don't have any indication.
Yeah,
that's not-
I've never gotten any indication from anybody
Yeah.
that is not the new.
So we don't need to say this.
It's typically.
We say it in there, we say continue this appropriation, but I don't think we need to
Okay.
be dramatic about it.
Okay.
So this might be a ridiculous question, but is there a reason we put these in the order that they are?
No,
Okay. And the only reason I say that is because I know in the previous report, the 988 surcharge was front and center.
Yeah.
And so, and it's like, maybe it's just a me reading it of like, when I see 1, 2, 3, 4, it's like, here's the one we like the most, second, third, fourth.
Is it
Fourth
alphabetical?
is the one that you were.
So,
which might make it alphabetical.
if we indeed need an additional 50 million. It makes it easier for me to be able to say, I'd like to have $1 surcharge. I can live with 50 cents because it gets us almost there, right there, right? If we win $1, we would be one of the highest in the nation. Probably number
The
one.
highest.
Yeah. If we go 50 cents, we'll probably be in the pack somewhere, right? The challenge that is presented with the surcharge is the use of the money is pretty restricted. And it's not restricted if you do an alcohol or even one state's taxing deliveries to your home. And they're making the delivery companies pay a surcharge if you receive a FedEx or a UPS or whatever. Now they're targeting that currently to transportation needs, but if you implemented something like that, you don't, I mean, you do it the way you want to do it, right?
Tax Amazon,
Yeah.
make Jeff Bezos pay.
Right.
We do need
So-
more road funding money.
Yeah, we do need more. So I like that idea,
Yeah.
but
So we'll play around with it. I think what we'll do, is we'll link, like I said, we'll link it to the recommendation, take it out of the body. Put it in alphabetical order, probably play around with the wording. And put a target in the link thing, say, just to remind people that our target right now is 50 and 70.
In terms of playing around with the wording, and I'm just being persnickety here, but on number 5, when you say, should the General Assembly decide against implementing new funding sources? To me, I wouldn't say that sentence. I would just have a line item budget being.
absent one of these options.
Or just start with a line item budget.
Yeah.
Yeah.
right.
Because truthfully, you're gonna need that in some form, and then if we get anything else, it'll be a mix.
Yeah, we'll play around with the wording. Shift that way. Any objections? To me,
So-
that's under formatting.
So it's 50 and 70.
Yeah, that's again,
So just
it
so
could
we're
swing, but I
so
think.
just so we're saying the same thing. Is that how we're saying it? Do we want to say 120? Like, have we thought about how we want to message this, or is that for?
Well,
us?
let's vote on this and then
Okay.
we can talk about
Okay.
the other part.
And
Okay.
I guess just before that 50 and 70, and we're putting that out forward facing, like. Do we need to explain a little bit more of the method of how we got to that 50 and 70?
We have all kinds of Excel files.
Uh-huh.
It's laid out a little bit in there. I think we tried to strike a balance between getting too into the weeds and not having
Right.
a bunch of
Uh-huh.
complicated Excel spreadsheets. So it's essentially to continue crisis response
Uh-huh.
and to expand the CCBHC footprint. And this is the state share of the CCBHC demonstration and continued kind of more contract funding for crisis providers.
Mhm.
That's the math.
that includes like the Youth Be Happy
Yeah,
program.
no, that's just
That's
that.
separate.
Yeah,
Exactly.
that's
See,
separate. So
yeah.
that's just that part of it. And then the other stuff, the only other one with money, but there's no way to come up with a number right now, is the Medicaid forecast funding, rate matrix funding. We don't have that right now. So there's no way to put a number on it. It's gonna go into the Medicaid forecast. Don't know what it is. And then the other ones with money, the Be Happy one, we do specifically recommend, and we have a model bill that does the insurance company pooled funding, which is a specific way to pay for it. I think we should just do that and not even mess with an appropriation. It seems like a hard thing to like be against, right? Like it's not that much money. The insurance companies are sitting on giant profits. They're slippery, but, and so the other things with money, I mean, there's gonna be a cost associated, David, with some of the high acuity needs stuff, but I don't think we have those costs yet, do we?
We don't, and the
Yeah.
hope is that we're going to reduce costs for residential. As
Yeah, so I think that it's almost gonna be a paid for type thing,
Yeah,
right?
yeah.
With that.
And what about like the whole cost for like the nursing home?
Yeah, I mean, I just
site,
we
like,
don't have costs.
we don't have, you know, and then the group home per diem. You know, so I guess that's where like, I think that caused confusion last time with legislators is because we were asking for CCBHC and 988 crisis, but this report addresses a lot more than that.
So that's where I think maybe if we do it this way by linking it in that part, we make it clear that we're just talking about that part.
That part,
of it.
yeah. Again, that gets, like, I've heard, well, we gave you money for that. Well, but that wasn't really money for that. That was money for this, right? Like they hear that dollars are given, right? And so if we're not specific in defining some of these, I don't know, some of those things like the high acuity youth group, like the nursing home, like group homes could maybe not get the attention that it needs.
I think that's kind of case dependent on whether we can get approval for a funding source outside of the general fund.
Right.
If you're going for the general fund, you're gonna get a lot of people that are gonna say, whoa, wait, didn't we give you 50 million a year already?
Right, yeah.
I mean, coming up with a number for the nursing home, for example, is not simple. Like that is not something we can just do and pull out of thin air. That's gonna require a lot of work. We have a rough number for the group home per diem. We can throw it in there. I'm not super confident necessarily in the numbers, but
Right, yeah, that's.
right. I
yeah.
mean, that's where the trickiness of all this stuff. A lot of this is like, we don't, and it sounds cliche, but the truth is you don't really know how much this stuff costs until you start doing it. And that's something that people always want to avoid that reality, right? Like, you know, we know exactly how much, but like, we don't know. Like we have an idea. We have a really good estimate about what CCBHC is going to cost us. We feel confident about that estimate right now. We also know that it could swing.
Right.
Based on the actual implementation because of the way this work is done. I will say top line, the number that was sort of raised at the last commission report was $130 million a year, and we are under that right. So I think we are well within our, like we're not, I think we'll avoid sticker shock from that sense with this report. But I mean, I'm happy to throw the number in for the.
Well, or we do the opposite. I guess that's what I'm kind of processing with the group. Like, if we're not really sure on the numbers, and yet we still have all these unknown, is that going to cause more confusion to folks? Maybe we don't call specific numbers until we know what that final ask is. I don't know. I know last session, Senator Kreider, that was the biggest issue, is people said, we don't know what you guys are asking for. And so.
Well, and particularly since there's a pretty large percentage of users that are Medicaid population.
Correct.
And so
about
very
83%
new,
amongst us.
kind of going into the last budget, Medicaid was going up $2 billion. And so it was getting a lot of scrutiny anyway. The fact that we got 50 million, it didn't have an outside funding source of really, yeah, it's pretty impressive, I think.
I don't know what the answer is, but I just.
I don't know if there's a part that I keep.
I mean, I don't know the answer either, but so what Zoe is saying is gonna happen again, and I think it just is, like, I don't think there's a solution. So we had the $100 million for Sentinel Deck 1. And there were other things, but that wasn't included in the $100. Legislators thought that the $100 covered everything. And so we're gonna do it again, and I don't think there's an answer, but we're gonna say 120 or whatever we're gonna say. And that'll be for the CCBHC in 90 day, but then all the other things will have a price tag. And the legislators will think, it's covered in the 120, it's not, so. I don't know, I don't think there's an answer, I'm just saying, that's that it will happen.
Right, because the two sides of it are that if you add everything together and we come up with a number.
It'll be.
And that number is
Yes.
really big, then you get laughed out the door, right? Versus like saying our number is this.
Yeah, I'm not saying we should do it differently, I'm just saying that will happen.
I mean, we can maybe in the legislative summary flag that there's additional costs associated
Maybe
with
we
a
need
couple of
to
the
say-
recommendations, like, and say, you know, that's, so like, maybe just like, maybe that's the answer, I think maybe,
Yeah.
that's not a great answer, but it's the answer, I think maybe is the legislative summary for the ones that potentially carry a state appropriation cost. So I'm actually not including the pool insurance model for Be Happy, like that should be like that, you all pay for it. But for the things that will carry a cost, say that these require additional appropriations.
Yeah.
And then kind of leave it. And then so
I agree.
then therefore, then if for some reason during session, because we know session's so unpredictable, like if for some reason one of these recommendations really like takes hold of a legislator and like, yes, I want to do this, then the cost conversation can happen.
And I think that prevents confusion. Yes.
How's that sound?
It'll be written clearly, but there'll still be.
It's always,
There'll still be confusion.
Yeah.
It will help.
Session is confusing. Yeah. You get that, team? All right.
You need a recommendation.
So yeah, I mean, I guess a motion to approve the content kind of as modified in this meeting.
I'll make a motion that we approve the content of the report with the modification discussed.
I'll second.
All in favor?
Aye.
Opposed? And the second motion would be to sort of authorize our team to continue to make stylistic and formatting changes.
You need a motion for that,
I think so.
somebody.
So, all in favor?
Aye.
All opposed?
I do have a question.
Sure.
Under the recommendations of possible funding.
Yes,
I haven't tracked them, please forgive me.
yeah.
But where do we stand with the opioid recovery money that we're receiving? Is
Great
there any of those funds that can be, used?
So yes and no, and so, yeah, I mean, I think yes, I think in terms of the allowable uses of that funding, I think for sure. It can be used. There's sort of two complicating factors. Number one, the way that works legislatively is that the plan has to be approved every single year by the state budget committee. Which is not a problem. They presented, I think, on Wednesday to state budget committee and it's approved. But it's done yearly, and so this year's plan
It's already made.
is already. This year, I think, is a calendar year, so January to June. And then the second, I think, more complicating, but also more, I think, in some ways. Promising is that there's a lot of settlements that haven't even come to us yet. Right? And so we can mention the opioid settlement funding. I think the worry would be that they're gonna gravitate towards that, right? So I don't, because it exists, doesn't require like any kind of additional.
Understood. I was just curious.
No, it's
If it had been
we've talked
discussed.
about it. It's a great question, and I think. But and we kind of like really vaguely reference it in the body where we say we're looking at other funding sources to offset. That's one.
Okay,
But it just from a mechanical standpoint, it's just a little messier.
gotcha.
Another revenue suggestion that I know some other states are exploring that I don't know how it would vote here, but is really looking at managed care and managed care tax and helping to fund some of the
Like
services.
taxes on managed care companies.
Mhm. And so some states are looking at that.
Well, now that we're not in the body anymore, we can run wild with new taxes. We come up with all kinds of things.
But I mean, that's another
Yeah.
thing worth exploring.
I mean, the resulting fight on that would make me
I know.
really
Yes.
nervous.
I know, me too. I was scared to even say it, but
I think let's just leave the words managed care out of it.
Yeah,
Completely.
okay.
Okay, so the only other thing we have, and this can be a short discussion or a long one, I'll leave it up to you all. So last time what happened with the rollout is we had FSSA put the report out of our press office sort of on behalf of the commission. Which is fine. I mean, it worked. I mean, mechanically it got out there. There was articles and reports on it and on it. But it did make it a little messy because this is not an FSSA report. So I'm just wondering, this is like a purely just almost like mechanical question. Like I do know each of the caucuses, caucusi, I don't know how you say plural caucus, but each of the caucus, the House and Senate Republican Democrat caucus, you have your own press office, right? Right. So, I mean, how would it strike folks for you all to, for the 4 caucuses to put this out when it comes out?
I think that's fine.
Yeah. I think it would be more impactful.
we do too.
Headlines, bipartisan approach to new behavioral health.
A month before an election, you know, coming together or something.
I think it's fine.
Okay.
We do.
We don't have to vote on that.
We do like a weekly newsletter thing that goes out electronically, and a lot of people sign up for that. It gets a lot of attention.
And then in terms of where it lives, I mean, we have a Behavioral Health Commission
Website.
page on our FSSA website. So it could still live there.
Do you want our comms teams to contact you then?
Yeah.
Okay.
Be great.
Do a joint press release and then
Yeah.
house them in our.
Because then this makes it clear that, especially going to administration change, that this is a legislatively driven thing.
We could do it from
I like that a lot.
the 4 members of the commission, do a joint press release. Say
I think that'd be powerful.
our legislative mandate is completed. See
Here it is.
such and such for the report.
Okay. Yeah, so we'll you know, do there now. I think it's something like maybe back half of September. Let's make sure we're certainly up on that. And then obviously you're gonna do, I mean, people are gonna do. other
And
stuff.
then, yeah, I was just gonna say other members who can, like Steve and myself, once you guys do that, then we can send a press release saying thank you to the legislature and pay that forward. So, because we're gonna want to get a lot of traction
Yes, of
behind,
course.
so.
Counties will do the same.
There's several of the local news channels have been kind of following. So I'm sure they'll be interested.
Oh, that's a good idea. Do we want to do a media release?
And that gets, you know, again, it's a lot easier for you all to do.
When mine goes out, I'll go to all the media outlets. Period.
Do we want to invite them, then release it?
Oh, we could
Could do
That's a
that.
great idea.
It'd be pretty powerful too.
like have them come to one of the chambers
Yeah.
and say, hey, we've been doing this work and what like to copy the report, answer questions. Kind of thing.
Lean on the outlets that have a presence at the state house and have it further
Yeah.
statewide.
Like Chronicle.
So that they don't have to go as far. And get as easy.
Yeah, let's look at that for like.
Should we designate a
when you're
comm
ready.
subcommittee? Or is that too bureaucratic? We don't-
I mean, it's,
Is it just we're small enough, it's just all of us, right?
Just
So,
do it.
yeah, we'll just do it.
Yeah,
Okay,
we
no,
each-
strike that from the record,
We each have our own people.
the minutes.
Yeah. Mhm.
Okay, well, that sounds like a plan. So I think we will get this final thing together. We'll send it out. I think we can still make stylistic and formatting changes. We're gonna kind of ask all of you to be proofreaders. If you know of like a dynamite proofreader that's not on the commission, we should have them do it too. Some people are really good at it. I'm not. You know, Senator Huntley's not here, but she's a former teacher. Maybe we can ask her to red pen it for us. And then we'll send it out. Plan would be from the caucuses, then all members kind of follow suit with their own organizations. All right, that's the official agenda, but obviously we'll open it up to any other business that wants to.
Are we going back to what Steve said? I guess my one question is, are we going? Okay. So in the appendix, we'll have a legislative summary report that we'll have specifically with our legislative asks that
Yeah.
Steve and I can take. Okay,
And that'll include indications of if there's a appropriation.
I want to thank everybody for showing up and participating. This has been really valuable. It has for me, and that's one of the reasons why I wanted to continue the Behavioral Health Commission. A lot of people think this was my idea. It was not. I met with the providers. We was 19, was it? Fall of 19, and I was frustrated. Had lost a friend to suicide, and I'm like, we just really need to do it. And they said, well, you want to try something big? And I said, yeah, let's do it. And so they gave me a couple ideas, and we moved the Behavioral Health Commission report without a no vote. I think nobody even really talked about it. Moved all the way through. And as we were getting out of session, COVID was starting to happen, and I'm like, you know, here's this big project, and I'm not even sure what's going to happen. So folks did a good job, all these people in the room, Jay, and gave us a good start. And attending the meeting on Wednesday and hearing the sheriffs, a couple of which I know personally, seeing the things starting to come together, and you're starting to see these really significant statistics has been really kind of surreal, I guess, just to think from where we had been, where we could still be, is really great.
Yeah. All right, one other thing, because this reminded me, I don't know why this reminded me of that. Do we want headshots in the report from you all? Right now we just have your name and title. That's it.
Fine.
Is that
I think it's standard.
headshots? Okay, well, our team will reach out to you for headshots, get them to them right away. So I don't know why your statement reminded me of that, but that was the one thing I meant to bring up. And then we just have titles, but last time we did quotes about why this is important to you. Is that?
That's cool.
Okay, so we'll reach out, but be thinking about, your quote about why this is important to you.
Yeah.
In your headshot. I don't think we have to vote on that. That's that's formatting to me.
Can I just, Senator Kreider, thank you for the thanks, but also thank you for your leadership and thank you for your vision and thank you for being our state's mental health advocate. You just really have led with perseverance, consistency, and just the utmost dignity for those with mental illness. And I just really am forever grateful.
Hey, Mariah, you take a picture. I won't post it out. Thank you. Thank you. All right, any other comments? All right, we are adjourned.
Thank you.
Thank you.